Dharmanand, Senior Consultant and Head of the Department of Rheumatology at Sakra World Hospital, Bangalore. For another unique topic in today's presentation, a rheumatologist's perspective of walking difficulty in elderly.
Good morning. See, walking for most of us is a reflex action. So we don't even bother how we walk. Walking has few components, as you all know, which I'll probably demonstrate. When you start walking, you plant your heel, there's a heel strike, then transfer your weight on the entire foot, and then rise. It's called heel rise. So, entire weight goes on the MTP joints and rise, and you have to clear the surface to again plant the foot on the next step. If a patient has got arthritis affecting the metatarsophalangeal joint, one process would be difficult. You will not be able to raise the heel, or toe rise is difficult. And if he has pain in the knee or hip, you would find it difficult to clear the surface. So the involvement of arthritis of the lower limb can affect gait in many ways. What are the arthritis which affect the lower limbs? Almost all the arthritis affect the lower limbs, but particularly in the elderly, osteoarthritis is the most common. Rheumatoid arthritis is again a common disease which starts in the middle age and invariably overlaps into the older age. Ankylosing spondylitis is a disease of young men, but young men do live long enough to become old, and they do have the consequences of this illness. And spondyloarthritis can start in the older age. And gout, of course, though it is a self-limiting disease, recurrent attacks of gout in the metatarsal joint can lead to destruction of joints and can lead to walking difficulties. And dermatomyositis, being a muscle disease, it causes weakness of the lower limb muscles and they have difficulty. And of course, osteomalacia again causes pain and weakness of the lower limb girdle muscles and makes them prone to fall, and they will be difficult to transfer. In addition, osteoarthritic process affecting the lumbar spine can cause neurogenic claudication, and lumbar canal stenosis can also contribute to the difficulty in walking in patients with rheumatic diseases. And in rheumatoid arthritis particularly, the difficulty in walking is never due to a single factor, it is always a multi-factor. Arthritis can affect the metatarsophalangeal joints, which is one of the commonest joints to get affected in rheumatoid arthritis. Knees are also very commonly affected and hips rarely. But any of this joint, if it is affected, it will affect the ambulation. And also arthritis of any duration would lead to muscle weakness. Quadriceps would become weak, the gluteals will become weak, and depending upon which area is affected, surrounding muscle becomes weak. This contributes to the difficulty in walking, and particularly transfer from sitting up position and a sleeping position. And also arthritis causes a lot of deformities. So it leads to poor lower limb function. So I have written upper limbs here. It's a lower limb function alignment. It contributes to walking difficulty. So when the alignment is not proper, so you have issue of balance. So that leads to wobbly gait, antalgic gait, which can lead to easy tendency to fall down. And also rheumatoid arthritis after many years can cause peripheral neuritis. And in elderly, age-related neuropathic also is very common. So all these things contribute. And of course, we should never forget pain. Pain is an important cause for difficulty in walking. If the patient, even if there is no deformity, if there is a lot of pain, they would find it difficult to walk. Neurogenic claudication, there is no deformity in the foot per se, but they have pain and that makes them difficult to walk. And osteoporosis doesn't contribute to walking difficulty, but definitely if they fall down, it contributes to fracture and subsequent difficulties. Osteoarthritis again is the most common arthritis to affect the elderly. Knees are the most common joints, and midfoot and also the first MTP again are very common sites of osteoarthritis in the elderly. And hip and lumbar spine osteoarthritis also can contribute to the morbidity. See, if somebody walks with a knee like this, how would they walk? They cannot walk like this. They'll end up walking like this. So they can trip on even a very minor obstacles. And osteoarthritis, depending upon which compartment is affected, either it can cause a genu valgus deformity or a genu varus deformity. So walking with this type of knee deformity definitely will increase the risk of fall, and also they would find it difficult to get up from a chair and walk, and it can definitely contribute to the falls. So people who have severe osteoarthritis, unless they use a support, they have an increased tendency of falling down. And arthritis which affects the midfoot can cause hindfoot valgus. So they tend to have a flat foot and a hindfoot valgus. And in addition to that, if they have a lot of pain in the midfoot, they would find it difficult to walk, and they walk with a more shuffling type of gait rather than clear-cut gait cycle which I had shown you. And arthritis commonly affects the first metatarsophalangeal joint here, and that can cause hallux rigidus or hallux valgus or hallux varus, depending upon the footwear pattern of the population we see. They can cause all the deformities of the foot and contribute to the walking difficulty. So they have difficulty in clearing the weight on their metatarsophalangeal joints. To raise the heel, we need to put all the weight on the metatarsophalangeal joints here. So if they have a hallux rigidus, they find it difficult. So they end up walking more like this rather than they cannot raise their heel easily, put that load on the metatarsophalangeal joints. In ankylosing spondylitis, the difficulties are different. They have generally over many years, they develop neck stiffness, and they develop what is called a Spocus spine. And if somebody has a neck like this, they would not have any clearance. So they have to walk like this. They can only see about few feet in front of. They won't feel confident in walking in the road because they can't see what's coming in front of them. So this could be a major difficulty. And they also commonly have, particularly the arthritis which starts little in a younger age group, they can have hip osteoarthritis, hip arthritis, which can again lead to difficulty in walking. They have antalgic gait. They can't raise their knee above the ground level. And of course, plantar fasciitis and Achilles tendinitis also very common in this group. Ankylosing spondylitis and spondyloarthritis commonly affect ligament attachment points. They are called enthesitis of the lower limb most commonly, and the walking can be very, very painful. And because of this posture, they also have a balanced issue. When somebody has to walk normally, they should have an alignment of the body. So if they have a forward stoop, this pelvis goes in front. So they walk with a very disadvantaged posture, and then again they are also more prone to fall down. And dermatomyositis, because the hips are weak, so they have difficulty in climbing stairs, and they also frequently fall down. Dermatomyositis is not uncommon in the elderly age group, and particularly some of them could be due to malignancy, as Chandrasekhar had pointed out. And osteoporosis is a factor which is very common in elderly, and age is the single most important factor for osteoporosis, apart from being a woman and postmenopausal status. So elderly patients, when they develop rheumatoid arthritis or ankylosing spondylitis or any autoimmune disease, they develop osteoporosis much more frequently. And also most of the autoimmune diseases, particularly the typical diseases of elderly like polymyalgia rheumatica, giant cell arthritis, the mainstay of treatment is steroid. So you add steroid to this group of patients, their risk of osteoporosis increases, and if they fall down, they are more likely to crack a bone. And once they fall down and fracture a bone, they'll all have a lot of fear of walking, fear of falling down. They'll all contributes to their walking difficulty. And again, they can have the same posture problem which occurs in ankylosing spondylitis because of the dorsal kyphosis. The Mother Teresa had osteoporosis. That's a typical posture. So it's extremely difficult to walk with that posture because it affects the entire body balance. So what are the factors which contributes to fall and walking difficulty in the elderly? I have talked about musculoskeletal parts of it. In addition to musculoskeletal parts, lot of elderly after 65, 70, they are prone to develop many neurological diseases like Parkinson's, Alzheimer's, peripheral neuritis. If they are diabetics of 20 years duration, they would, that is the age which they develop peripheral neuritis due to diabetes. And strokes. Somebody has got a stroke, they will have a residual stroke, and that also would contribute to their walking difficulty. So if these patients, in addition, they have musculoskeletal symptoms also, their walking is severely compromised. And in addition to neurological problem, they can also have cataracts and age-related retinal degeneration and auditory decline and peripheral. All these things contribute to the walking difficulty. Somebody who, to walk normally, they should have a good proprioception, good hearing, good vision. All these things contribute to effective walking. So we walk reflexly because our vision is good, we are hearing normally, because we get feedback from the sound surrounding. So we know something is coming nearby, so we can take appropriate steps to stay away from the moving vehicles. All these things contribute. When any one of these sensory aspect is compromised, the walking could be difficult. So cardiovascular disease, again, that the cardiovascular compromise, postural hypotension, and even breathlessness can contribute to difficulty in walking. And all of them, most of them will have at least one medical disease like diabetes, anemia, COPD, and depression. So these all contribute to either directly to walking difficulty, also contribute to their fear of walking. And again, Chandrasekhar stressed the aspect of polypharmacy. Elderly would go to many consultants, many specialties with many complaints. And invariably, everybody gives a prescription at least 3 to 4 drugs. And many times there is an overlap of drugs. I commonly see people taking multiple brands of pantoprazole. One somebody will give Pantacid, somebody will give Rantac, third doctor, because no doctor has a time to look at what other doctors have given a prescription. So they will, the moment they give a drug, they give antibiotic also. For some reason, almost all antibiotic prescriptions are associated with the PPI. I don't know why, but it is the truth. And somebody gives a painkiller, they'll give a PPI. And neurologist also gives a PPI. So because almost all patients would complain gas. There is no elderly individual without a problem of gas, because as we all age, we accumulate quite a few. We accumulate silver in our dentures, gold in our teeth, and lot of gas. So, this is a problem. So we accumulate, we are ready to get back to the Mother Earth. So we have accumulated lot of elements. All these things contribute to polypharmacy. So we have to look at drugs which can cause postural hypotension. Lot of antihypertensives can cause postural hypotension. Sedatives, sleep disturbance is very common. So somebody will give you zolpidem, somebody will give Zolfresh. So there is a lot of polypharmacy is there. So somebody has a time to look at all these prescriptions, eliminate unwanted drugs, can make a long way in improving their quality of life. That's the reason I think we need more and more geriatricians. So they are the ones who are likely to do it. None of us are likely to do it. And a few words about fall. Fall is a natural sequence of difficulty in walking. Somebody has a difficulty in walking, they are more likely to fall. All of us fall down once in a while. But 30 to 60% of the people do fall in a year. But if somebody falls more than 3 times a month, he can be considered as a frequent faller. So these are the guys who are more likely to have bad consequences. And fall leads to more serious injuries. For some reason, elderly fall more frequently, and also women tend to fall more frequently than men. And they have more osteoporosis. They're more likely to have hip fracture and other osteoporotic fractures. And head injuries can be fatal. Even a young person falls, unfortunately falls on a hard object, he can die instantly. So we have seen our own doctors and colleagues falling down during their rounds, hitting their head and dying. So this is a bigger problem in elderly. And once they have fallen, the fear of falling down, which is very, very important, that will lead to decrease in mobility. Once somebody has fallen down on going for a walk in a park, they will probably find 101 reason to stay away from. I have a little bit of cold today, I have a little headache. So they would try to avoid that walking because they are scared of walking. So once they are scared of walking, they would hardly get out of home. And they get more and more deconditioned. So more deconditioned, when they try to walk, they'll become more weak and more likely to fall. So they'll reinforce their belief that they're not going to be fit. So they tend to avoid the activity. Elderly are very, very, very efficient in camouflaging their difficulties. Sometimes it takes 5 years for somebody to know that their husbands have Alzheimer's, because they have a knack of hiding their difficulties from their wives, even from their wives. So ultimately they become dependent and may lead to social isolation because they stop going out to the social functions, etc. And definitely it affects the quality of life. So we need to identify people before a fall can occur. And as I told, fall or fear of falling definitely can affect the function. And also, once they have a fear of falling down, you have to probably go back and assess what are the potential causes. It gives us a prompt to look for neurological condition, check their nervous system, check their vision, check their hearing, etc. So always ask for a history of fall, balance and gait problems at every clinical visit. It's not a bad idea to ask an elderly, if you are seeing them every 3 months, in the last 3 months have you fallen down? This may be an important history to ask. And if they said yes, they have fallen down, just trying to find out whether we can identify a cause. If they say that there was a water, oil there and I stepped on it and fallen down, it is probably not important. But if they say that they were just walking in the park, just buckled and fell down, so that may be an important history to be further evaluated. There are few risk factors in the elderly. Muscle weakness. As we age, we lose muscle mass. So sarcopenia is an important cause for muscle weakness. Age is an independent risk factor for fall down. Somebody has fallen down, they have some risk factor, so they are likely to fall down. So this is one history. Somebody has a history of fall. These are the patients needs to be evaluated strongly. And of course, medications, many medications, vision and hearing deficits, impaired cognition. If somebody is using assistive device, this is a clue that they might be at a risk, because elderly resist. Even a 75-year-old person says that, why don't you use a walking stick? I'm not old, doctor. So if 75 is not old, what else is old? But they don't perceive, because they feel it as below their, they feel ashamed of using a walking stick. But if an elderly decides to use a walking stick, that means something he is really scared to walk. So this is individual, we should probably evaluate for other risk factors. And of course, environmental factors. Cluttered house. Most of our wives are very fond of changing the anatomy of the house. Suddenly they'll say, the sofa should be here, sofa should be here. So if you're elderly living with you, be careful about this. Suddenly you change because they get up in the night, go to the toilet. They tend to go to toilet much more frequently. They know that nothing is there in the track, so they just walk. But if you have changed the alignment of so you have put a stool or a round pot there, it is a chance that they may tumble. So always look at the environmental factors, and almost all the factors have all the falls have more than one risk factor. So you need to eliminate and decrease the risk factors. This is one Bayes criteria. This is one, you can look at the internet. There are nice websites which says that drugs which are inappropriate in elderly. I'm not going to look at this, all the drugs. I'm sure Dr. Benjamin would discuss this area. But that it is available. Just write Bayes criteria, drugs for elderly. So you get the chart, which are the drugs which could be inappropriate in the elderly. I think I'll skip this. So how would we evaluate? Syncope evaluation. So probably it may not be a bad idea to check blood pressure in the sitting and getting a position, standing 1 minute after standing, 3 minutes after standing. If they have a significant drop in blood pressure, these are the patients who could be helped by different means, like even a stockings can help. And assess the gait and mobility pattern. and vision assessment, hearing, cognitive impairment, pharmacy. These are all we have discussed already. Vitamin D deficiency is an important factor. A simple test which you can do in the clinic is get up and go test. If the patient is sitting in your consulting chair, ask them to get up, walk up to another 6 or 7 steps, turn and come back. So it's get up and go test. If I can demonstrate some, patient is sitting here, ask them to get up, walk about 6 or 7 steps, ask them to take a turn and go back and sit in the chair. You can identify a lot of difficulty in getting up, because many times we don't really observe them sitting and getting up. So this is an opportunity, and if they have difficulty turning, they wobble like this, we know that they have a difficulty. They may have a postural hypertension, they may have balance issues. So simple get up and go test could help us to evaluate their balance and mobility issues. These are the few other things like multiple SS here, 10 SS, structure, anatomy, stride, sepsis, speed of walking, strength. So these are all the things. Examine their shoes, sensorium and sight. We can mini mental scale examination. Sometimes this can be done with one small sheet. If you have an assistant, we should be able to do it for you. That will help us to know about their cognitive defects. BP I have already touched. Lower limb strength, tiptoe on getting up from the chair, so which I have already tried to tell you. Balance could be checked with the tandem walking and standing on one leg. A 70-year-old man can stand on one leg. His balance must be extremely good. And gait, observe, get up and go test I have described, and review medication at every visit, because between your visits, the patient would have visited one more consultant for some other reason and have one more prescription, which might duplicate some of your drugs. So what as a rheumatologist we can do? We don't have a solid control over the other aspects, but it is if we can identify and do an appropriate referral to the physiotherapist and suggest walking aids, that will be helpful. And as a rheumatologist, I would like to treat aggressively the rheumatoid arthritis. Elderly do tolerate most of the disease modifying drugs. We can give methotrexate safely. Look at their creatinine. If the creatinine is good, if the creatinine clearance is above 60, you can give methotrexate reasonably safely. They also tolerate leflunomide, sulfasalazine and hydroxychloroquine. And treat the arthritis aggressively early, so that they don't develop the deformities. And the foot remain normal at the end of 6 years, 7 years, they can continue to walk normally. If I find a rheumatoid knee inflamed, I do inject this joint, because they will have less pain, that will improve their mobility. And of course, physiotherapy becomes a cornerstone. Elderly can exercise. I have seen in my own flats, one young lady brought her father, who was about 75, 80-year-old man. He was so frail, she used to literally hold his hands, bring him to the gym and make him do things. At the end of 6 months, that gentleman was walking on treadmill on his own. He was doing cycling, he was doing a little bit of weights. So daughter with good determination had definitely improved his muscle strength. They can do weights. With a minimum weight, 1 kg dumbbells, they can improve their weight. So that will improve their muscle strength, and they can improve the balance. Balance could be improved with few specific physiotherapy tools. Standing on a wobbly platform, sitting on a ball, gym ball, all these things can improve their balance. And I would review their medication list periodically, and I would treat aggressively osteoporosis if it is there, and that will probably, even if they fall down, the risk of fracture will become less. So as for fall history or fear of falling routinely in everybody, look out for preventable causes and modify the risks. Always know that the cause of falling is multifactorial, so intervention has to be multifactorial. So we need to treat the treatable diseases. We cannot treat maybe Alzheimer's or maybe some other neurological disease effectively, but we can always treat rheumatoids and osteoarthritis very effectively. We will review the drugs periodically. Never forget to review the drug periodically, and make sure that little bit of environmental modification is suggested. Bathrooms should be dry, So the bathroom is in one area people can fall down, slippery bathrooms. Our loo could be our water loo. So we have to be careful. And environmental factors should be modified. If a lot of children are there in a house where elderly are there, ask the mothers to keep the toys in a basket after the children play, because a toy is left over, could elderly steps on the toy, it could lead to a fall. And falls can be costly, so prevention is the key. Try as much as possible to prevent a fall. And of course, rehabilitation approach is very, very important apart from treating the rheumatological diseases. I think I'll stop here. Thank you very much.
Thank you, sir, for the talk. Dr. Dharmanand has presented a very complicated topic in a very simple terms. The question is, the topic is open for discussion, and Dr. Dharmanand will be happy to take questions.
Any vertebral fracture can cause walking difficulty. I just want to know, like thoracic, lumbar, or anything, because some of them move on to the clinic and other things. So trying to evaluate, she is difficult to walk, and evaluation find hip and other things are normal, and she has got vertebral fracture and above like T10, 8 or something like that. That also can cause walking difficulty or fear of walking?
See, the vertebral, if it is isolated thoracic spine vertebral fracture, would cause difficulty in walking due to pain itself. One. Number two is, even if there is no fracture in the lumbar spine, there is no fracture in the hip, one fracture which could be missed in elderly is the sacral fractures. Sacral fractures are never picked up by your routine X-rays. You may need an MRI or a CT scan or a bone scan. Somebody has a lot of difficulty in the pelvic region. They have difficulty in turning in the bed. They find it extremely difficult to get up from the chair. And you find only a T8 fracture. I would suspect a pelvic fracture in addition. One clue might be a pelvic X-ray might show a subtle crack fracture in the pubic ramus. Most patients who have a sacral fracture here can have a pubic ramus fracture in the front. So these are the clues where they may have more difficulty in walking and transfer and ambulation. Transfer is transfer from a sitting position to getting position, transfer from a bed, supine position to a sitting position or a standing position. This difficulty is very common with sacral fracture, which is missed by the traditional conventional X-rays we do.
Why does Alzheimer people have difficulty in walking? People with Alzheimer, how do they have difficulty in walking?
Alzheimer, per se, they don't have a physical reason to stop them from walking. But Alzheimer's, because of their cognitive defect, they don't walk. They avoid walking. For some reason or other, they refuse. Most of the Alzheimer's, they prefer to sit. We don't know their mind because they don't communicate well. So we don't know whether they have an inherent fear of walking. So it is more of a cognitive problem rather than actually a physical problem. And after some time, they get deconditioned. If they don't walk for 1 year, 2 years, of course, their proximal muscles would be weak.
You said that corticosteroids may have to be introduced for arthritis. Is it intra-articular or oral?
Both, madam. If it is a rheumatoid arthritis with knee arthritis or an arthritis occurring only in the ankle or any joint for that matter, upper limb joints, yes, isolate. If it is not getting controlled with the disease-modifying drugs, we give intra-articular steroids. In a condition like giant cell arthritis or polymyalgia rheumatica, the treatment is systemic, oral steroids.
Won't it cause risk for cortisone-induced diabetes?
Yes, definitely. See, it's always a double-edged weapon. So steroids, of course, you know the list of side effects. Can be 1-page, 2-page list of side effects. But when we decide that the benefits occur more than the risk, then we do give. See, an elderly with polymyalgia rheumatica or giant cell arthritis are at risk of losing their vision. Polymyalgia rheumatica patients, they have severe pain in their shoulder. They can't even lift. They can't do anything. They can't lift, keep a small bottle up on a shelf. They can't get up from the chair. They have so severe pain, they won't respond to anything else except steroids. In that case, if the diabetes worsens, we have to manage the diabetes and try to minimize the steroids, give it for the minimum shortest period of time, smallest dose which is effective. That's and always give calcium, vitamin D and bisphosphonates to reduce the risk of osteoporosis. So steroid, once you decide to give steroids, you have to have a management plan. It is not only steroid, you have to manage what is going to happen because of the steroids as well. And probably will vaccinate the elderly because steroid will increase the risk of infections as well. So we give pneumococcal vaccines. Whatever we can do to reduce the steroid side effects, we would do. Monitor the diabetes very closely.
Thank you.
This is the last question, please.
What would you advise a patient who has got multiple problems with his spine and has walking difficulties, like a diffuse involvement of the cervical, thoracic and lumbar spine, and has a real walking difficulty and nobody wants to treat him? What would you advise?
Nobody wants to treat it. See,
I
I would assume that the difficulty is predominantly lumbar canal stenosis, degenerative, maybe a degenerative kyphoscoliosis, and he is not fit for surgery. So I would assume that your patient is not fit for surgery because he may be a diabetic with a little bit of cardiomyopathy, so nobody is going to give anesthesia. Maybe physical therapy. Look at the other modalities, which can be improved. What we can improve is we can look at his vitamin D status and improve that. We can get him to the physiotherapist, improve the muscle strength in the lower limb and also the spine. And we can send them to pain clinicians. They may be able to give an injection, epidural injections or facet injections, facet blocks. Pain could be reduced so that mobility could be improved.
Thanks.
Dr. Dharmanand, thank you, sir.